Good afternoon, or good evening, or good morning, what it may be. It's my great pleasure to welcome you at the occasion of the 173rd Cutter Lecture. My name is Bert Hofman. I'm the chair of epidemiology at the Harvard School of Public Health. The Cutter Lecture has been given once or twice a year since 1912 under the terms of the bequest of John Clarence Cutter. He was a graduate of Harvard Medical School, very much devoted to global public health. It is the oldest lecture series in epidemiology and preventive medicine, and it has always been presented under the auspices of the Department of Epidemiology, of what is now called the Harvard Chan School. Today's Cutter lecturer is Dr. Anthony Fauci. Dr. Fauci, I don't think he needs much introduction, but you know, he's the director of the National Institute of Allergy and Infectious Diseases at the NIAID. He's also the chief of the lab of Immunoregulation, and he has been advisor to 7 presidents, including the current one, just back from the press information. And he has, since the early 80s of the last century, worked on infectious diseases, starting at HIV/AIDS. It is my, Dr. Fauci, distinct privilege to invite you to present the 173rd Cutter Lecture under the title COVID-19, Lessons Learned and Remaining Challenges. Dr. Fauci, I invite you to take the Zoom floor.
Thank you. Warm greetings, and thank you so much for that kind introduction, Dr. Hofman. I'm very honored and pleased to give the 173rd Cutter Lecture on preventive medicine today. And as you can see from this first slide, and as is the lessons learned and remaining challenges of COVID-19. And what I'd like to do is divide the discussion into 6 elements and to briefly highlight the salient features in each. Starting off first with the epidemiology, which is now very well understood after 2 years of weathering through this outbreak. Currently, as of yesterday, there had been almost 270 million cases of COVID-19 in the world, with over 5 million deaths. And it is estimated by some that that is in fact a very low number and a gross underestimate. The United States, as we know, unfortunately for us in this country, has been one of a handful of countries that has suffered the most from this outbreak, with almost 50 million cases and now creeping up on about 800,000 deaths since the beginning. Like other countries, we've experienced this unusual phenomenon of multiple successive surges and waves, which is schematically diagrammed on this particular slide. Of note, with each particular surge and wave, we never get down to what we would consider to be a reasonable baseline. And actually, what has happened over the past several months following our summer surge with the appearance of the Delta variant, which I'll get to in a few moments, note where we are on the far right-hand part of the slide, where we began coming down from the summer surge of 2021, and we reached a point of about 70,000 cases, and then things turned around. We had an increase in cases such that as of yesterday, we had 115,000 new cases, over 8,000 hospitalizations, and 1,000 deaths averaging per day. In essence, we are literally on the threshold of a winter surge back up again, unless something changes dramatically. Let's take a quick look at the virology. Very well discussed now over the last couple of years. This is a beta coronavirus, an RNA virus, which has 4 structural genes, the most important of which is the S or spike protein. This protein, as you know, is responsible with its receptor binding domain to bind to the ACE2 receptor on multiple tissues, particularly the upper airway, which is the modality of entry into the body, as well as the lung, cardiovascular, and GI tissue. Again, because of our extensive experience over the last 2 years, the transmission is well worked out. Exposure to infectious respiratory fluids, at first thought to be due only to respiratory droplets, but as our experience heightened over the months and year, it became very clear that aerosol particles also are a major modality of spread, being deposited on the mucous membranes in the mouth, the nose, or the eyes. Transmission, although it was felt to be an issue on contaminated surfaces or fomites, now is well realized to be very much less common as a mode of transmission, maybe even non-existent. The risk is greatest in enclosed spaces, particularly with poor ventilation and during certain behaviors such as exercise, hence the issue with staying away from gymnasiums, singing, hence the concern about choirs in churches. Now, there are a couple of unusual things about this virus that we did not fully appreciate in the early months of 2020. And that is about 1/3 at least of patients who get infected with SARS-CoV-2 never develop any symptoms at all. But probably even more important is that close to 60% of all the infections resulted from someone who was without symptoms, transmitting it to an uninfected person. That person was either without symptoms and would never develop symptoms, or was in the pre-symptomatic stage of infection. A realization that really transformed how we thought about this infection, including the importance of wearing masks. The clinical course is protean. For those who do develop symptoms, they are very similar to the flu-like symptomatology that we're all very familiar with. However, there is one unusual, unique aspect of the presenting symptoms, and that is a peculiar loss of smell and taste, which generally precedes the onset of respiratory symptoms and can continue for a period of time following the resolution of the acute infection. Now, for those who do develop symptoms, they're mild to moderate in about 80% of people and severe or critical in up to 20% of people, leading to a wide range of case fatality of those who get severe disease, from either 2.3% or up to 20% in patients requiring mechanical ventilation. There are certain subgroups who are at an extremely increased risk for severe COVID-19 disease, and those are older individuals, as well as persons of any age with certain underlying medical conditions dominated by obesity, hypertension, diabetes, chronic obstructive pulmonary disease, and other organ systems dysfunction. When one does develop severe COVID-19, it is again dominated by the acute respiratory distress syndrome. But as more experience accrued, it became clear that neurological, cardiovascular, renal injury clearly does occur, and pathogenic processes such as hypercoagulability, and particularly in late stages, a hyperinflammatory syndrome. Also, children, and sometimes, but rarely adults, get what's called a multi-system inflammatory syndrome, very reminiscent of Kawasaki syndrome. There are post-COVID conditions, some that are readily explainable by residual organ system damage. For example, someone who has very severe pulmonary involvement recovers, but has residual organ system dysfunction manifested by diminished pulmonary function tests. But there are also something called long COVID, where individuals have the persistence anywhere from weeks to several months of signs and symptoms that are not completely explainable by any readily apparent pathogenic process. This slide shows the entire range of symptoms, but the more common ones of long COVID are profound, sometimes incapacitating fatigue, particularly post-exertional, muscle aches, shortness of breath, mood disorders, lightheadedness, unexplained tachycardia and palpitations, as well as brain fog, as they refer to, which is an inability to focus or concentrate. There have been a number of therapeutics that have been shown to be effective in clinical trials. The two major components are one that target the virus, such as direct-acting antivirals, such as remdesivir, which is approved by the FDA, but that's must be intravenously administered, but also a whole array of monoclonal antibodies, which when given early in the course of disease, have a positive effect in preventing hospitalization, severe disease, and often death. For advanced disease, which is generally characterized by an aberrant inflammatory or immunological response, simple drugs like dexamethasone have shown to be effective in people with advanced disease, as well as certain monoclonal antibodies like tocilizumab and baricitinib, which block certain components of the inflammatory cascade. Of late, we have made a major investment in doing discovery and development by focusing on vulnerable targets in the SARS-CoV-2 replication cycle to design drugs to inhibit these targets. This is very reminiscent and actually has been modeled against what we did with HIV decades ago, where we took the replication cycle of HIV, identified vulnerable targets like the protease enzyme, the polymerase enzyme. We are doing now the same thing with the replication cycle of SARS-CoV-2 as schematically diagrammed on this slide. And in fact, there are two drugs that are noteworthy. One is Paxlovid, a protease inhibitor together with ritonavir, developed by Pfizer, which when given within the first 3 days of recognizable symptoms in a randomized placebo-controlled trial, showed almost a 90% reduction in hospitalization and death when compared to placebo. Of note, there were 10 deaths in the placebo arm and no deaths in the treatment arm. Also, another drug, molnupiravir, developed by Merck and Ridgeback, which showed a less of an effect, but nonetheless a notable effect of about a 30% decrease in hospitalizations and death, again, in a randomized placebo-controlled trial with 9 deaths in the placebo arm and 1 death in the treatment arm. Now let's talk about vaccines, because this is truly the scientific success story of a very complicated and often bumpy public health process. The development of a vaccine, or more than one vaccine, from the time the virus was first identified and its sequence published in January of 2020, 11 months later, in December of 2020, multiple vaccines following very large, tens of thousands of randomized placebo-controlled trial showed a high degree of efficacy and safety and was going into the arms of individuals 11 months after the sequence, a truly unprecedented accomplishment in biomedical research and applied research. So quickly, a word about the importance of these vaccines. You can divide it into vaccine construct and vaccine immunogen. The immunogen is used in most of the vaccines, is called S2P, which was developed by Barney Graham, Kizzy Corbett, and others, collaborators from other institutions. That is, they stabilize pre-fusion form of the spike, which is highly immunogenic. 3 platforms use it: mRNA, adenovirus, and recombinant protein. 6 developers. 1, BioNTech Pfizer, already has received a full BLA. 2 have received emergency use authorization, Moderna and J&J, and others are in the queue applying for an emergency use authorization. I'm going to quickly go through some of the data to show you how impressive it really is. First, efficacy was shown in clinical trials. These are some of the papers that are now classics. The Pfizer-BioNTech showing 95% efficacy. The Moderna product showing 94% efficacy. J&J, which was tested in multiple countries, showed a 72% efficacy in the United States and varying degrees of efficacy in other countries such as Brazil and South Africa. Now, in general, you might often see that efficacy in clinical trials is better than what is ultimately shown in the real world setting. However, that is not the case with COVID-19 vaccines, because the effectiveness in the real world setting is very clear. If you compare an unvaccinated person in the era of the Delta variant, which is very problematic, if you compare in the United States unvaccinated people with vaccinated people, there's almost a 9-fold increased risk of testing positive, an 11-fold increased risk of being hospitalized, and a 14-fold increased risk of dying from COVID in an unvaccinated person compared to a vaccinated person. Now, things really got complicated with the impact of SARS-CoV-2 variants. These are a number of the variants that we're dealing with. One that has dominated us for the last several months is the Delta variant. Why is that the case? Right now, we have 99.5, it's gone down a little bit, but that's a lot. 99.5% of all the variants sequenced in the United States are Delta. This is critically important, not only for us, but globally, where almost 180 countries are dominated by Delta. The Delta variant is particularly problematic because of its high degree of transmissibility, more than 2 times more than the Alpha variant, which dominated our country prior to the Delta. Importantly, viral loads are up to 1,000 times greater than in the Alpha variant when you look in the nasopharynx by CT level in the nasopharynx. Things get even more complicated because in the era of Delta, even though the vaccines were shown to be highly effective in the real world, first with inklings from Israel and then England, we started to see that after 6 months or so, immunity begins to wane, as shown on the left panel, for all 3 of the vaccines used in this country, waning against infection and even against hospitalization and, to a lesser extent, death across all age groups, as we've seen from a lot more data from Israel than we have thus far in the United States, which led to the importance of booster shots for SARS-CoV-2. So let's take a look at the effect of boosters. First, in vitro studies indicate that booster shots truly remarkably increase the antibody titers against multiple SARS-CoV variants by multifold. Here's some representative examples. This is the Moderna product comparing the booster shot with the 2 shots following by about 28 days, where you would see peak in the light blue. If you look at the younger age, 28 days after the booster, it goes from 55 to 875 antibody titer. In the elderly, it goes from 32 to 706 in the boosted group greater than 65 years old. With the Pfizer BioNTech, very similar. Focus for the sake of brevity on the blue bars. In the younger individuals, 1 month after the second dose, the level of 50% serum neutralization titer was 241, whereas 1 month after the third dose, it was 1321. Similar degree of substantial enhancement with the third dose as seen in the elderly on the far right-hand part of the slide. This laboratory data has been translated into clinical effect, because if you look at some of the studies, again, here from Israel, when you look at a boosted population 12 days or more after the booster, there was an 11-fold diminution in confirmed infection and an almost 20-fold diminution in the rate of severe disease in the boosted population compared to the two-dose population. These are some of the data. Again, this is data from Israel. If you look at admission to the hospital, severe COVID in the middle panel, and death in the right panel, compare in the pink red those who received only 2 doses, and in the blue, those who received an additional dose for a 3-dose total. Again, if you look at the efficacy and safety of the BioNTech, when they looked at a 2-month interim analysis, they found when you compare the boosted to the unboosted group, there was a 95.6% efficacy. Again, these are the data shown schematically where the red, it says placebo, but that really is a 2-dose regimen compared to the blue, which is a 2-dose regimen plus a 30 microgram boost of BioNTech. Now, if things were not complicated with Delta, they become more complicated with the Omicron variant. Why did this initially, and even a bit more to this day, cause alarm? These are schematic diagrams of the spike protein of Delta compared to the spike protein of Omicron. As you can see, many, many more mutations leading to amino acid substitutions in Omicron. In fact, there were more mutations than seen in any of the isolates. About 50 mutations in the total virus, about 30 in the spike protein, and about 12 or more in the receptor binding domain of the spike protein. 3 questions arise immediately. What is the effect of Omicron on transmission, on immune evasion, and on severity of disease? So what do we know as of literally yesterday? First of all, it appears that Omicron has a transmission advantage over Delta. We're seeing that clearly in South Africa, when if you look at the early November, and then something very unusual happened at the end of November, the beginning of December, and that is an almost vertical spike in the number of new cases, which when sequenced were almost all Omicron. Now you look at this map and go from early 2021 through April, July, October, and then on the far right, November, December. The peach colored was the original beta that dominated South Africa, the B1.351. However, take a look at what happened in the middle. Beta disappeared a bit, replaced by varying degrees of other variants until In the far right with the blue, we have Omicron completely dominating the situation in South Africa. What about severity of disease? Some good news here, although warning, it's preliminary, but we're seeing it in more than one country. Namely, that when one looks at the ratio of infection to hospitalization, there are many fewer relative numbers of hospitalizations with Omicron compared to a similar situation with Delta months before. The need for supplemental oxygen is less, and the duration of hospital stay is less. Recent data from the UK also indicate that there is, in fact, a very strong suggestion of a less severity compared to Delta. What about immune evasion? Good research data from South Africa, published in a meta-archive, showed that when you look at reinfections, namely people who were infected with Beta or Delta, and look at the rate of reinfection of either Beta or Delta compared to Omicron, and very clearly there was a threefold greater risk of reinfection with Omicron than there was with the original Beta and Delta. Now, these are a bunch of studies. Rather than go through each of them, the common denominator of them all are that initially it was shown literally a few days ago, if you look at the dates on these, that neutralization of Omicron by sera from people who were vaccinated with 2 doses of an mRNA was dramatically diminished. And this is shown on the data here. So look at the left-hand part of the slide. These are 21 days after the second dose. Purple is Omicron. With, if you look at the neutralization titer, the virus neutralization titer, and this is a pseudovirus assay, it's dramatically diminished for Omicron, but also somewhat for Beta and wild type. But look what happens 1 month after the 3rd dose of Pfizer-BioNTech. The Omicron in purple, which if you go to the top part of that, it says 154, which is the PVNT50 titer. It's very comparable to what the titer against wild type was at peak time after the 2nd dose, which was 155. Bottom line is we feel you're going to get reasonably good protection after a 3rd dose boost against Omicron. But that remains to be seen in the clinical setting. But the initial suggestion is favorable. Because of that, the CDC has expanded their COVID-19 booster recommendations so that anyone and everyone over 18 years old of age or older should get a booster. And right now, Pfizer had just recently extended that to 16 and older. So let me close by just throwing things up that are constantly being talked about. What's the end game for us in 2022 and beyond? What is going to happen? Well, I don't have a crystal ball and we don't know. We do have good vaccines, highly effective. The good news, the bad news is that we have a large segment of our population, 60 million people, who do not want to get vaccinated. So how do we look at this? When you have a pandemic, there are different phases. The pandemic phase, which is the explosion that we all been through. Then there's ultimately has to be a deceleration in the acceleration of cases. Then there's control, elimination, or eradication. We're not going to eradicate this. The only thing we ever eradicated was smallpox. Elimination is aspirational, could occur, but I doubt it. We've done that with polio in this country, with measles in this country, with yellow fever in this country, all by vaccination campaigns. Then there's control, and that's really the question that we're facing. At what level of control are we going to be able to get back to some degree of normality? One thing for sure is that 115,000 cases a day and over 1,000 deaths is not an acceptable level of control. So a combination of getting more people vaccinated, even if that requires vaccines that have to be required, namely required for employment, required in the federal government, or what have you. We've got to do better with vaccines, but also we've got to be able to implement other mitigation methods. And importantly, we've got to vaccinate the rest of the world, particularly low and middle income countries. Because until we have a truly global response to this global pandemic, we will not be able to control it in a global manner. So I'll stop there and thank you for your attention.
Dr. Fauci, thank you very, very much for this beautiful overview and the 173rd Cutter lecture. We have invited people to have questions in the, not in the chat, but in the Q&A facility, and I will read a few for you, and you don't mind, given that this is an epidemiology presentation. The general question: how do you view the performance of epidemiologists and epidemiology in this pandemic?
Well, it's been a critical part of our understanding of the dynamics of this outbreak, particularly some of the modeling that has been done. You know, models are as good as the information and the assumptions you put into the model. But as we got more and more data, and then the assumptions became more and more solid, epidemiology and the associated modeling has been an extremely important part of our understanding and of our prognostication of what to expect. So from a scientific standpoint of all of the disciplines involved, I think epidemiology has shown very, very favorably throughout this.
Thank you very much. Another question, there are lots of questions about vaccines, obviously. Thank you for the overview. As a general question, the new mRNA vaccines, what do you suggest that they will have as a possible effect for other infectious diseases? Is this a real breakthrough for other diseases as well, is one of the questions we have.
Oh, I absolutely think so, very much so, because right now we already, because of the excitement that's been generated by the spectacular success of the mRNA, that people are using the mRNA platform for HIV, for malaria, for tuberculosis, and even for some cancer vaccine. So, I mean, it's not the only good platform, but when we made a decision, and this is I think an interesting anecdote for your audience, Dr. Hofman, is that when we made the decision to make a major investment in mRNA for COVID, we actually got some significant criticism for people who were saying, with such an important historic outbreak, how could you try a vaccine that has never, ever been shown to be effective for anything until now?
I remember the comments, I must say.
Yes, and I was the brunt of those comments. So I feel really good about celebrating the extraordinary success, which, by the way, we scientists know, but I think the general public doesn't know, that that platform technology and the immunogen design was the result of a 2 decades of investment in basic biomedical research. It wasn't something that we just decided on at the last minute, that's for sure.
Yes, thank you very much. And quite a number of questions about, of course, the Omicron. What do you, as a more general question, what do you expect for the US in this?
Well, the doubling time of Omicron is about 3 days, which is much lower, which means it's spreading faster than Delta. The way it took over Beta in South Africa makes me pause and wonder if that's what we're going to see here in the United States. But South Africa has a much different demography than we do. They're an under-vaccinated population. They have about 30% of their population is vaccinated. They have double-digit HIV positivity, which we don't have in this country. So there are differences, but it's starting to look like if it does what we think it's going to do within the next couple of months, it's going to kick Delta off the map.
So you mentioned the what is it, the many mutations, the 30 in the spike protein and perhaps 20 in the receptor binder region. What do you expect when there are so much more mutations than, say, compared to the obviously the wild type and the Delta variant? What does that say for infectiosity, and what does it say for the possible severity of disease that you would expect from this?
Well, you know, you can learn a lot more about its evasion of immunity and its transmissibility. It doesn't tell you much about severity of disease. That you just have to do clinical observation. So we predicted, it was pretty easy to do. The molecular virologist looked at it and said, you got a problem with immune evasion. And in fact, we did with the 2-dose blocking of infection, but so gratified that the booster dose brought it right up to where you want it to be. The other thing to warn the audience is that, and I'm sure many of your viewers and listeners know, that antibody titer isn't the only manifestation of good protection, particularly when you're talking about protection against severe disease, that memory B cells with their maturity, with their affinity maturation and T cells, et cetera, all play a major role, much more so in protection against severe disease than protection against infection.
So, yes, can you predict something about the number of mutations, and particularly in the receptor binding domains, on the efficacy of vaccines, existing vaccines, or is there nothing to be said about that?
No, it's absolutely, and that's the experiments that not only have been done. It's really, in some respects, exciting, because this is something unfolding right before us. Yeah. You know, usually you're lecturing about something that data was 10 years ago. Now I gave you data from yesterday. Over the weekend, there are 2 or 3 major groups that are going to assay sera from people who were vaccinated with 2 doses, sera from people who've gotten a boost, and sera from people convalescing from infection, and looking at pseudoviruses to determine what the impact is on the level of antibody predicted protection. So it's all about what the effect is going to be on a vaccine.
Thank you very much. I have 1 or 2 other questions because, and then I would like to close. One question, in fact, from one of our colleagues in France was, what is the possible role of monoclonal antibodies to prevent long COVID? Is there a role anyway? And can we say something about this already?
You know, we don't know. That's a good question. Long COVID, I'm sure most people are familiar with it, is the persistence of unexplainable at least unexplainable by pathogenic processes that are recognized. Symptomatology, usually profound fatigue, muscle aches, sleep disorders, etc. In people who recover, there are theories about why that's the case. Is it persistence of virus, particularly maybe even dead nucleotides that are inducing an inflammatory response, which is causing persistence of symptoms? Theoretically, there was some data that suggested, and then it's been a bit disproven, or at least not consistent, that vaccinating people who have long COVID can diminish the signs and symptoms of long COVID. There have been some studies that say it does and some that says it doesn't. So I would think the same thing would be true for the effect of monoclonal antibodies.
Yeah. Thank you. Two perhaps final two questions that come up a lot actually. Vaccine hesitancy. How, as a profession, as a discipline, scientific on the one hand, profession on the other hand, how should we address this? What are your comments on this?
My comments are that I'm beset with great frustration, Dr. Hofman, because we could really
join the club here.
Yeah, we could really knock this out of the park if we got the overwhelming proportion of people vaccinated. You know, there are multiple reasons for vaccine hesitancy. I've dealt with that with measles and other vaccines, but the degree of hesitancy that we are experiencing now with COVID-19 vaccines has a lot to do with ideological persuasion, which is really completely unacceptable from a public health standpoint. How you could decide you don't want to get vaccinated because you want to make a ideological or political statement. I mean, that is contrary to all the fundamental tenets of public health, but that's what we're facing. So I don't have a good solution to overcome that, except something that people don't like to hear, and that is getting vaccine requirements. You know, some people use the word mandate. That's a sort of radioactive word, but a requirement that if you want to be in class in a university or in a college, you got to show proof of vaccination. The federal government already has a requirement in the sense of if you want to be in person in your office, you got to be vaccinated. So maybe that's going to be able to get us over the hill on that. I don't know.
We have it at Harvard here as well, as you know. We have also, we use it, the word mandate still. Perhaps a final question, but perhaps also an important one from the Q&A. How do you see the role of the US in the global distribution of vaccines?
Well, I've always said, and I've said this publicly, so I have no problem telling it you here, is that I think we have a moral obligation to use our resources and wealth and to encourage other rich countries to get vaccine doses to low and middle income countries. And in that regard, the United States, I believe, is doing a good job. We have given already 300 million doses to over 110 countries, more than all the rest of the world combined. We have either given or will pledge 1.1 billion doses by the first half of 2022. And we've given $4 billion to COVAX. I think we need to do more. I really do. Even though we've done more than all the other countries combined, I still think we need to do more, both because what I feel is a moral obligation, but I think it's enlightened self-interest. If we have virus raging in the rest of the world, we're going to continue to be beset with variants that might, in fact, evade the vaccines that we've given to our own citizens. So I think it's absolutely critical to involve the rest of the world in our effort to control this.
Dr. Fauci, thank you very much. This was a wonderful Qatar lecture. We have for you a little memory of this. I ask Copelia now to show, yes, here it is. It is in appreciation for delivering the 173rd Qatar lecture on preventive medicine on December 10, 2021. The Department of Epidemiology at the Harvard T.H. Chan School of Public Health extends its deepest thanks to Anthony S. Fauci, MD, And we thank you very much. In the meantime, now it is black, but I think it is on the way to your home already, Dr. Fauci. Again, many thanks for this wonderful presentation. And yes, Coppelia, I can thank you now, as well as Sean D'Antonio and Dave Sampton and Haley Arnold for organizing from our side so well this Qatar lecture. For those of us, I should say, who are in the Gregorian calendar, I wish you a very happy holidays, a good start of the next year, 2022, when we hope to see the better of the side of our pandemic. Once again, my great thanks to Dr. Anthony Fauci. I wish you a very good evening and thank you very much.
Thank you, sir. It was a pleasure to be with you. Thank you.
Thank you.